couple of disclosures not relevant to this talk. Now, the inspiration for this session came about 2 years ago when we were running FISIC, and I was actually chairing a session on anterior knee pain in athletes. And during that session, one of our very respected speakers, Peter Myers from Brisbane, came out with a comment which was, and of course you would never do a tibial tubercle transfer on an elite athlete. And I picked him up on it at the end in the Q&A and said, are there really no circumstances in which you would do it? And he said categorically not. So I mentioned a case that I was managing at the time, which was a 25-year-old professional footballer who, in a few short weeks, had developed significant lateral trochlear edema with patellar instability, symptoms of subluxation. And his TT-TG distance, tibial tubercle to trochlear groove distance, was 25 millimeters. And I felt that this was too much to expect a medial patellofemoral ligament reconstruction to unload that side of the joint. And he looked at me and he said, Sam, I would not do it on this player. I will make a point. And he went out to the audience and he said, put your hand up if you have ever done a TTT on an elite athlete and they've got back to sport. And 4 people put their hand up. And he looked completely flabbergasted. He said, no one's ever put their hand up, let alone 4 in one session. Now, he stuck to his guns, and I believed him, and I treated this guy conservatively, and he got back to sport, and he's just signed a new 2-year contract with this club because he's playing so well, so he was right. But it got me thinking that actually we don't really have a consensus as to how to manage patients with patellar instability, elite athletes with patellar instability. We have managed it in the past by denying its existence. So we've just said, oh, people with really bad patellar instability never make it into the elite levels. And that is actually rubbish. There are many remarkable individuals out there who have achieved elitedom, even with patellar instability. And you don't need that much dysplasia when you're putting a knee through these sort of forces while playing sport. You don't need that much dysplasia to dislocate, and once you've dislocated, of course, you're going to dislocate again, and it could be a career-ending injury. And the most powerful thing we can do to normalize a patient's anatomy is a tibial tubercle transfer, which has historically a bad reputation. This is a girl who had a tibial tubercle distalization and medialization with a medial reefing procedure 8 years ago on the left knee. And this photo is taken 6 weeks after I did an identical procedure on the right knee. You can see that the scars are a lot smaller, there's a lot less dissection, and you can distalize through that little transverse incision just as easily as you can through a whopper down the middle. Now, there are some cases where a TTT is not the right thing to do. This was a 34-year-old professional rugby player who presented with a first-time dislocation and a TT-TG distance of about 15 millimeters. But actually, his main problem was that he had significant dynamic valgus due to chronic MCL laxity. So he was dropping into valgus, as a result of which his patella dislocated. Now, he was treated with a double bundle MCL reconstruction and an MPFL reconstruction. You have to compromise a little bit on the tunnel position for the MPFL, but he was delighted. He immediately felt that there was improved valgus stability in his knee. He returned to rugby, and since this operation, he's become his country's most capped player. But there are other situations in which I can't see any solution other than a TTT. This was a 16-year-old international gymnast who dislocated her right patella for the first time the night before the Commonwealth Games while practicing her floor exercise. Now, the MRI scan confirmed the diagnosis. It showed she had a TT-TG of 21 millimeters, which is high, and the X-ray showed she had an MPFL avulsion fracture, that little flake of bone off the medial side of the patella. So, remembering the mantra, thou shalt not do a TTT on an elite athlete, I thought I'd go in, I'd fix that fracture back, reef up the medial soft tissues, and see how she went. And she recovered quite quickly and well and returned to tumbling, but had a further acute event and represented with this, horror of horrors. The twin fixes pulled out. Clearly, the MPFL has never healed, and she's now accepted the fact that her elite career is at an end, but she wants a definitive procedure to provide patellar stability for normal day-to-day activities. So we did a TTT with an MPFL reconstruction on her, and she immediately felt her knee was better than it had ever been throughout her entire life. She realized that actually her left patella was rather unstable as well. She managed to return to elite gymnastics. And knowing that I was giving this talk today, she actually sent me this video. The bars aren't quite so relevant for the knee, but you'll see when she's tumbling, she's putting quite a lot of force through this. And for those of you who are thinking, well, she's not actually landing any of them, she does in this last one, although I'm sure the physios are all noting that she's dropped on the right and bending the right knee. And the final case I want to present is a 25-year-old professional footballer who saw me about 3 years ago, having had a second patellar dislocation. After the first one, his local knee surgeon had gone in, trimmed out some loose bodies and done a medial reefing, and then he dislocated again. And he came down to see me specifically to say, was there any surgery that could provide him with a stable patella and allow him to return to football? And we talked about MPFL reconstruction, but his TT-TG distance was 26 millimetres. That's really high. And I said you could have that, and that would return you to your pre-dislocation risk, but you would still be at high risk of dislocating. And we could do a TTT, but there is no guarantee you will get back to elite sport afterwards. So he didn't really like that Hobson's choice, so he stuck with conservative treatment, returned to playing, and came back to see me 2 years later, having dislocated again. And this time, he'd taken off most of the articular cartilage from the medial facet and the apex of the patella. He also had this rather nasty impaction fracture with a rotated intra-articular fragment. And he, just like the gymnast, said, I don't care about my career anymore, I just want a stable patella going forward. So we went ahead and did a TTT MPFL on him, and again, he felt his knee was better than it had ever been. He had the confidence to try and return to elite level football. Now, I did this operation 6 months ago, and he's kicking and running, but he's being plagued by patellar tendinopathy, which he's had his entire career. So I cannot call this a success. But I can't help thinking I let him down, because if I had actually persuaded him to have this done 2 years before, I would have saved him the chondral damage that is probably going to plague him for the rest of his life. So, do we know how to manage these players? Is it sport-specific? Is it sex-specific? What should we be doing? And we've got a really good panel today to try and help us answer this. First of all, obviously, we need to make the diagnosis, and we need to understand the anatomy that led to this, and Charles Wakely is going to talk about the imaging. Then we've got Simon Lack, talking about physiotherapy. Presumably all of these patients should have a chance at physiotherapy first off. Then we've got Andy Williams talking about his approach to the surgical management of patellar instability in elite athletes. And we've got Andy Metcalf focusing a little bit more on tibial tubercle transfers. And finally, we're going to talk about something that is often ignored because we don't understand it, and that is the role of rotational malalignment. And my co-chair, Jo Stephen, is going to tell us all she's doing about that. Thank you.
Thank you, Sam and Jo. I have nothing to declare. I'm going to run you through imaging. Patellofemoral instability. Subjectively, it's the feeling of giving way on flexing and extending the knee, and objectively, it's lateral subluxation or dislocation. As in any body, it basically depends upon the anatomical morphology and also the secondary biomechanics. But in the elite athletes, we also have to consider the extreme increased stress that they put their bodies under, and also their extreme expectations from their own bodies, from their staff, and from their surgical outcomes. The patella is basically a sesamoid bone that is floating freely in the breeze. It's held in a crucifix vertically by the extensor mechanism and laterally, horizontally by the retinaculae. It's further pushed and pulled into the trochlear groove by the extensor mechanism. The end result is frank dislocation, beautifully shown here on MRI with the classical features in a patient with trochlear dysplasia, a flat femoral trochlear sulcus here, damage to the infraremedial margin of the patella and the medial retinaculum and MPFL, and a lovely bone bruise here, which is probably from the relocation injury rather than the dislocation injury. Patellar stability effectively, as I said, depends on static constraints, which is the anatomy and the morphology, and then the dynamic influences, which I'll discuss now. Before we go any further, I'd like to remind you of the known accepted risk factors. This is by De Jure in 2001, which are trochlear dysplasia, lateralization of the tibial tubercle, and patella alta. Starting with the morphology, we're going to look at the patella and the femoral trochlear sulcus. The trochlear sulcus is the most important. You can see the normal V-shaped trochlear groove here, which helps maintain the position of the patella. Therefore, you can understand why with someone who has a flat trochlear sulcus or a very shallow one, there's a greater propensity to patellar dislocation. And in extreme cases, you get these prominent lateral femoral boss. Patella, similarly, there are multiple different shapes, some of which are more propensity to dislocation than others. The most helpful sign, I think, on conventional radiology is the crossing sign. If you follow Blumenstadt's line down here to the floor of the trochlear groove, you can see a prominent spur or nipple where the bone from the trochlear groove projects anteriorly to the anterior femoral cortex. I don't use skyline views. I'll tell you about that later if necessary. I think they're unreliable. This is MRI, which has completely revolutionized our imaging of trochlear dysplasia. The axial images in particular, you can see the angles and the lengths of each individual facet. You can see the hyaline cartilage quality, and it has transformed our imaging. Some people use the lateral trochlear inclination here of the trochlea. If it's less than 11 degrees, there's a 93% sensitivity for trochlear dysplasia. I personally don't measure it, and I don't record on it. The most helpful thing of all is the depth of the trochlear sulcus here. Anything less than 3 millimeters has 100% sensitivity for trochlear dysplasia. However, be careful. In a study we presented in 2006, we noticed that there's a mismatch between the bony trochlear sulcus and the cartilaginous trochlear sulcus, such that here you can see a very shallow bony trochlear sulcus which has been completely effaced by the overlying hyaline cartilage. For those of you who like numbers, we found that there was nearly a 17-degree difference between the bone and the cartilage trochlear sulcus. Finally, moving on to the biomechanics, there are two main important features. One is the patellar height, and two is the Q angle or the tracking lever arm. Patellar height, this is an absolute minefield. There are numerous methods. I've only mentioned a few here. None are reliable, and unfortunately, they've all been based on original conventional radiographic material using bony landmarks and some of them using the tibia. If you look at the Insel-Servati ratio there, for example, the X measurement here can be changed by just the shape of the patella, whether it has a long inferior pole. The Y measurement can be changed by not only the length and the shape of the patella, but also whether there is a high or a low attachment to the patellar ligament. You can dial up virtually any number you like. And actually, if we just sit back for a second and think about it, these measurements are not relevant. We're talking about patellofemoral instability. Therefore, we're interested in the patellofemoral joint, which is the patellofemoral articulation, which is represented by the articular cartilage of the trochlea and the patella. So you can understand the excitement when people introduced the patellotrochlear index in 2006, and it became adopted by a lot of the knee surgeons. They looked at the articular surface overlap here of the trochlea in relationship to the patella as a form of ratio. We then validated this in a study we did in 2009 for patients with trochlear dysplasia and came to the conclusion that it was a far more clinically relevant measurement than all of the other previous bony measurements. However, not surprisingly, and even as co-author, I've actually stopped using that measurement now. And I use effectively the same measurement, but much simpler. I simply measure the articular cartilage overlap. And if the overlap is less than 6 millimeters, it is what I call functional patella alta. Finally, the Q angle, the clinical Q angle, which you all know about. You can see in this gentleman here, or lady, I'm not being sexist, this gentleman here, with genu valgum, you can see there's a hugely increased lateral pull from the patella from the increased Q angle. Now, as radiologists, we can't measure the Q angle because we don't image the pelvis and the leg at the same time, we only image the knee. What we do, though, is we measure the lateralization of the tibial tubercle in relation to the trochlear sulcus. We started off doing this with very complex 3D reconstructions, superimposed and measuring lots of lines and angles. But now with the advent of the PACS multi-viewer systems, which you've probably all got access to now, I simply click on the trochlear groove, scroll down and measure across to the tibial tubercle and measure the lateralization. Click and scroll. It's as simple as that. Anything more than 20 millimeters is thought to be relevant. I can't finish without mentioning supralateral fat pad edema, originally described by Lageron as conflict between the proximal lateral patellar ligament and the anterior crest of the lateral femoral trochlea with intervening fat pad edema, which you can see beautifully demonstrated here. There's great discussion whether this is due to maltracking, to impingement, or both, but quite frankly, in my opinion, it is nearly the most important factor of all is patella alta. So that's the end of the talk apart from these last two slides. What do I actually do to help the surgeons and you as clinicians? I consider the main predisposing factors, and what I do effectively is measure the causes and effects. So final slide, the causes. Number one, is the trochlea dysplastic? 2, is there a lateralization or subluxation of the patella, and is there evidence of recent dislocation? 3, what is the patella height, and in particular, is the functional patella alta? 4, what about the patella hyaline cartilage and the trochlear hyaline cartilage? Very easy to overlook, very important. If it is damaged already, it will limit the surgical options. 5, is the supralateral fat pad edema present? Now, these are effectively just 5 radiological observations. I'm not saying any of them are absolute, and I put these, what I call these, is my 5 pieces of a radiological jigsaw, which in turn is only one piece of the clinical jigsaw. And that is to then pass forward to you for your clinical and treatment algorithms. Good luck. Thank you.
Thank you.
This is my disclosure of interest. I thought I'd start with this lecture by just going back to the literature and having a look at how common is this problem really. And admittedly, this obviously is not in an elite setting, but certainly this is a good spread of instability or incidence of instability. And this was done on 24,154 incidents of primary dislocations, and it came out that 42 per 100,000 person years was the incidence of a dislocation. And the graph there just demonstrates how the age and the incidence of the dislocation. Further study there done by Sanders et al. Looked again at the incidence of this and reported fairly similar statistics to the previous study. And what I felt was really of note here, particularly if any of you are working with adolescent populations or certainly working with academy sport, is that the peak incidence looked to occur around this 14 to 18 years. So if they're going to get a dislocation, it looks to be occurring quite young. What was quite interesting about that Sanders et al. Paper is that they went on and they looked at some of those features that we've just been introduced to about dysplasia and patella alta. And they found that in 17% there was evidence of dysplasia, and in 15% of the presentations there was evidence of patella alta. But that didn't account for 67.7% of other potential factors that were contributing. And me being a physiotherapist, obviously, I'm there thinking, right, of those potential factors that are contributing to patellofemoral instability, which of those can we intervene in and potentially have a positive effect? So I thought, well, let's explode that 67% odd and see which factors there could potentially be to equate for it. And other structures perhaps equates for a further 5%, 15% maybe from a soft tissue or a connective tissue disorder. But then there's this aspect of biomechanics that we've just been introduced to. Perhaps the load, the volume or intensity of the training that these guys are undergoing could be contributing to their incidence, or perhaps there's some psychosocial factors as well. What I also sort of got thinking about when asked to do this presentation was that when we said, oh, how common is it really, but how common is it within elite sport? And I thought to myself, well, perhaps I need to try and sort of display this diagrammatically. And I sort of came up with this picture. So this is a Simon Lack production. And you can agree or disagree. But those sports with large multi-directional components versus those with the unidirectional components, if you add in a patient or an individual that's most unstable against someone who's least unstable, I feel like there's this potential zone of individuals who perhaps won't survive in elite sport. But perhaps that yellow curve demonstrating those who can survive in elite sport, if we intervene effectively as physiotherapists or conservatively, perhaps those two ends that are separated currently could start to come together. So the key question for me is how are we going to intervene conservatively to have a positive effect in these individuals? And as I alluded to, there are some three key bits that I think that we have tools that we can positively impact on. The other aspects, outer dysplasia, other structures, their connective tissue, I'm no good at affecting those. So I've got zero interest. Well, not zero interest, but I think I'm not particularly good at doing anything about it. So let's focus in on the things that we can do. So the first thing I thought with regards to the biomechanics, this was a group of the elite athletes that I work with, volleyball athletes, and this is how they move sometimes. So we did a screening and we looked at how they moved with a box jump. And as you can see, from a sort of patellar dislocation risk perspective, this isn't particularly great. So how are we going to do it in terms of teaching them to move better? Well, we could cue them, so we could give them some cues in order to try and help to get them to move better. Perhaps we could provide them with feedback, so using the imaging, such as we've done here, and then also facilitation, so even simple things like putting band around their knees as they jump and get them to be maintaining pressure into that band whilst they jump could reduce some of that peak knee valgus that we're observing. The other way is to train them to be able to move better. So perhaps in some individuals, they don't have the capacity to move better. And as we were discussing upstairs in the cycling talk, sometimes that's not purely about strength. And perhaps that might be the way in which they're recruiting the proximal musculature from a neuromuscular perspective. So developing their neuromuscular patterning using a lot of work that sort of promotes abduction, external rotation in around the hip, but neuromuscularly. So we're talking high repetitions, high sets, high reps, high frequency in order to elicit that change. But then we need to take that improved neuromuscular patterning and we need to make them strong at being able to do it. So we've got to add load because their demand is high, and that could be through strength training, so going into a strength phase but continuing to consolidate that improved movement pattern. And then the final section here on the right is to say, right, well, they're strong, we've got an improved neuromuscular pattern, so let's make them be able to recruit that quickly. So just as one example, getting them to do a box jump or some power drill. The other way is that we help them to move better. So we've educated them on moving better, we've trained them to move better, but for some people, they just can't recruit that pattern. So there are tools, there are adjuncts that we have in our toolbox conservatively that might help and facilitate. And from an orthoses perspective, and listening to the help of my podiatry colleagues in order to really give the best advice as what to be doing from a foot-up perspective. But taping interventions in terms of facilitating movement patterns can be extremely powerful and effective. Then, certainly with the emergence of Tim Gabbett and his work, there really needs to be this continued consideration of training load and the capacity to handle that load. And where this discrepancy lies, significantly increases the risk. And so we have a role to play, I feel, with regards to educating that. So we've just got our new intake of scholarship athletes at the University of East London, where I work. And every year, same scenario. They have a fairly light summer. These guys come back, get put pedal to the metal, and lo and behold, their training load over their capacity is off kilter, and as a result, they significantly increase their risk of injury. And I don't see patellofemoral instability any differently, or patellofemoral dislocation. Then this is a bit in vogue, really, with regards to the psychology, how big a role this has with patellofemoral instability. I think it's got a big role, really. I've seen a lot of young adolescents particularly who are extremely nervous about what's going on, the instability that they feel. So we're not only training them to become more robust from a physical perspective, but psychologically we need to get them to be more robust as well. So we've got to try and increase their confidence with more complex movement patterns, and a lot of that comes from taking some of this training into real life scenarios and situations where the training mimics their sporting demand. Definitely increasing their resilience and their capacity, certainly towards sort of managing injury, but also aiming to reduce some of their anxiety, answering their questions with regards to what fear, or equally sort of modifying their pain in order to optimize some of the mechanics. So the summary really is this is get them young if we can. 14 to 18 years was the highest incidence of patellofemoral instability, so if we're going to have a positive effect, that's the most likely age group where we're going to have that positive effect. Identify the possible drivers which may differ. So we've got to assess each of these individuals as individuals and make sure that the intervention is targeted appropriately, whether that be neuromuscular, strength, power, facilitation with various adjuncts. Be realistic about expectations versus demands. Some people may not have that training capacity in their locker, and they maybe need to be educated with regards to that, and some of that is them figuring out how to be an athlete. Biomechanics, teach, train, help, or facilitate, as I've gone through, and optimize this load versus capacity equation. And finally, continually working on this psychological component throughout their treatment or conservative management by building confidence and decreasing concern. Thank you very much.
Normal people who have dislocations or subluxations of their patellofemoral joint have patellofemoral dysplasia and/or an axial malalignment of the lower limb. Athletes are a self-chosen group of people. The forces that apply with natural selection affect them. The weak go to the wall. Of those hundreds of children who have talent, a very small minority will make it. And if you get to 21 in professional sport, you're generally put together very well. And so if they dislocate a patella with a normal patellofemoral joint, it requires great force. In rugby, a big whack on the medial side of the patella might knock it out of place with maximal external rotation and quadriceps contraction. And so the reality is that it's pretty uncommon. But the other reality is that those athletes who have a dislocation of the patellofemoral joint actually don't have normal joints. They have dysplasia. And in certain sports and certain positions, it's more common. The classic is the front row or second row in rugby. Front row players have dysplastic, flat trochlear grooves, have external rotation and increased Q angles. The second rows, being tall, have patella alta. And patella alta is the most powerful radiological indicator of occult patellar instability. And so the people I see are actually those with abnormal joints. I rarely see those with normal joints because it doesn't happen very often. If it does happen in a non-dysplastic joint and there's no loose body, then of course I could treat those non-surgically. They'll do very well. The gentleman I mentioned yesterday who had a septic arthritis after an ACL reconstruction, had to give up his career, had both his patellae dislocate previously and made a full recovery, played for England for a long time before the disaster with his ACL, because he had normal patellofemoral joints and he had no surgery. The only indication for surgery in an otherwise normal joint is a loose body. If you treat people non-surgically who have a dysplastic joint, there are two aspects. It takes 3 or 4 months to get back, and unfortunately there's a high recurrence rate. Whereas if you operate, and we'll go into that in more detail later, the return to play is around 4 months. And so if I've got a player who's got a dysplastic joint, and I fear redislocation, because it can be a disaster. I'll give you some case examples later, but if they dislocate, they may have the unlucky dislocation where they shear off the back of the patella. The patella has the thickest articular cartilage in the body for a reason. You cannot afford to lose it. And so, as a prophylactic procedure in elite sport, and I emphasize elite sport because it is different, the pressures are different, I'm happy to waste a few weeks of recovery and operate. So the majority of those present to be the first-time dislocation who have dysplasia, I'll offer surgery to. Now, how do you do the surgery? Well, in normal patients, the non-athletic or non-elite athletic population, like most of us, I would imagine, I look at the various factors and I like to correct them. If they're loose on the medial side, an MPFL reconstruction, if they've got a large Q angle or a high patella, I might alter the position of the tibial tuberosity. If they've got a very tight lateral retinaculum, occasionally I'll do lateral release. What I don't tend to do is deal with trochlear dysplasia. It's a bridge too far. I've been a consultant since 1997 and I've seen a lot of knees because that's the thing I do. And I've sent 2 patients for trochleoplasty. One was Dutch and she went to see Bereiter in Germany, and the other one was a nurse in London, and she went to see Tim Spalding. Even the French, who've pioneered trochleoplasty, and particularly in Lyon, are doing less and less. The cost of that surgery, in terms of the trauma, is often a price not worth paying. Not always, but certainly for an athlete, I wouldn't even consider it. When you treat athletes, you have to treat them slightly differently. They are special. It's not a fault of theirs, it's how it is. And the pressure on them to get back and perform is immense. And we may or may not be able to argue about arthritic risk long term, or there's no evidence, I'll say it again, there is no evidence that patellar realignment reduces the risk of osteoarthritis long term. But I need to get patients back to play as soon as is safe and keep them back. And one of the most important maxims I've learnt, and it was when I read a book on foot and ankle surgery when I used to do that, and there was a chapter by Carl Lewis's doctor. He said, you must do as little an operation as you can to get a result. And that result is return to play and remain playing. Because there's always a price for an operation. The bigger the operation, the bigger the price. And I don't mean my invoice. I mean the price of neuromuscular inhibition, of sensitivity of scars and wounds, etc., etc., etc. And the bigger the operation, the larger the risk of complications. And also, the slower the recovery. So I worked with Peter Myers, who was mentioned earlier on, and his rule was that tibial tuberosity transfer didn't allow athletes to get back to the highest level. And he taught me they get back to a representative level, like county level, but not to elite sport. It seems, from what Sam says, he was wrong. And so we did medial stabilization surgery. In those days, it was a complicated procedure, and it often didn't work very well. But MPFL reconstruction has become established, and we now know how to do it because of the work of people like Joe Stephen and the lab at Imperial College, and it's a reliable procedure. I don't add the tuberosity transfer because that's how I was brought up, as I've mentioned, and because it costs time, there are more complications, and what I do, I believe, works. So let's look at the results. In preparation for this talk, I got my last 20 MPFLs in elite athletes out. So it's retrospective, it's my work, all the inherent bias, etc. And there are no knee scores, because I haven't seen the patients. But the great thing with athletes is they cannot escape. In the majority of cases, you can follow them up on social media, etc. Of the 20 knees, 13 were for instability, in other words, dislocation. Every one was dysplastic. Average age was 21, so they just about got there before they got found out. And all of them got back to play, but 11 of 13 only got back to the same level. But the reality is that's a pretty good result. And the mean return to play time was 6.6 months. 2 of them were outliers with a long recovery, as you can see there. And if we remove those, the return to play was about 4 months. The other 7 cases were undertaken because there was malalignment leading to chondral damage. They had lateral patellofemoral osteoarthritis that had become career-ending. So these were really extreme cases. It was a last chance saloon. They'd never dislocated, but you could see on evaluation that they were malaligned and dysplastic. 6 were dysplastic, 1 wasn't. And they had a lateral retinacular release, medial patellofemoral reconstruction, and open drilling of both sides of the joint to stimulate healing. Average age was older because they were relatively stable joints and had got further in their careers. And 2 failed to return to play. And I have actually lost one who's a hurler. And although trying to get hold of the physio in Dublin, I've not managed to nail that one just yet, but I'm sure he'll be in touch soon. So that's, at best, pretty modest result. So but as you just learned, if you do it for instability, the results are excellent. So let's have a look at a few situations. This lad's an Irish goalkeeper. He's had 2 previous dislocations in the previous 5 years. And the 3rd time he didn't get lucky. I'd seen him previously for an MCL injury, and his patella and trochlear chondral surface was intact. As you can see here, his 3rd dislocation, he was unlucky. He got back, but to a lower level. This 22-year-old is now 32. He played for England under 23s and had his first dislocation. And I rehabbed him, being a good, dutiful, non-operative surgeon as you should be in sport. He had 2 dislocations because I didn't operate. But we got pretty lucky because he didn't do much damage. He got to 9 months after the first dislocation and was desperate. I remember seeing him in the corridor of the hospital. He came in for a scan, and he wouldn't let me go. It was insistent that something had to be done. And he was really the first one that gave me the courage to do this in an elite athlete. So I did an MPFL and a lateral release. He is still playing Premiership rugby, 10 years on. This is a scan from the summer. He had a whack on his knee and it swelled. And his patellofemoral joint is damaged, as you can see, but actually really is not bad. That is an MPFL reconstruction in a dysplastic trochlea at 10 years. That's pretty good. This guy was a disaster. He had his first dislocation of his patella in December 2013, and he was coming towards the end of his contract at the Premiership club, and he wanted a move, as they describe it. And so he insisted on non-operative treatment, despite having patellofemoral dysplasia, as you can see. And he got himself back together, got on the pitch, started scoring goals, and he signed for another Premiership club in August 2014. Unfortunately, the beginning of the following season, he dislocated. And unfortunately, I can't show the original scans, but he sheared off from here to here. That's pretty important for a running athlete. So no other option but to operate. He had a lateral release, he had an MPFL reconstruction, and open drilling. He was playing for an excellent club with excellent medical staff who were brilliant physio, brilliant doctor, people who kept the heat off me in terms of the time to return to play. The non-medical medical experts have got a short attention span and a short amount of patience. But these two men looked after me and allowed me the time required with the player to get better. He had to have an arthroscopic debridement at 6 months, but never looked back from that. He played at 15 months from surgery. He then signed a deal this January for 10.4 million quid, which will probably see him through in terms of his family, his children's education, and a nice house. The surgery works. So in summary, athletes are different. I do have a different approach to normal people, but most of the people I deal with have dysplasia, and yet I don't do bony surgery on them. Less is more, ladies and gentlemen. Thank you.
And thank you for inviting me to a great meeting. I've got no commercial conflict of interest to declare. We have had some research funding on this topic. But I should probably explain that I've actually cheated a little bit with this talk, and I'm not relying on my own experience entirely. I've had great training from Bristol, and a lot of this talk has been influenced by that training. So patellar dislocation. Quick rough guide. 70% is the figure to remember. 70% of activities, first dislocations happen during sport. 70% of first dislocations happen during adolescence, as we've already seen. And 70% get ongoing problems after their first dislocation. They may get pain. About 30% in our most recent systematic review have a redislocation. But a lot of people get subjective instability. They feel like the kneecap's going to come out all the time, like it's always going to go. And yes, I accept there is a psychological component to that, but actually, it's because they literally are about to go out. So I always do I use a superlateral portal for my MPFL reconstructions, do a scope before. The trochlea is way over on the right. The patella, as you can see, is hanging off the side of the trochlea. And I would say I see this for probably the majority of the MPFL reconstructions I do. So these patients are telling us they feel horribly unstable, and they are. This is pathological anatomy. This is taken from one of our recent reviews, and I would suggest to you that the management of patellofemoral instability is in fact relatively simple. As Mr. Williams has already explained, you identify what the major anatomical abnormalities are and deal with them. If you have significant patellar alta, it's worth correcting. If you have severe trochlear dysplasia, and most of these patients don't have severe trochlear dysplasia, they have a flat trochlea. But if they have severe trochlear dysplasia, I would argue that trochleoplasty is a very good operation. If they have a normal, relatively normal height and relatively normal in terms of dysplasia, they all have some dysplasia, then an MPFL reconstruction is an excellent operation. MPFL reconstructions. as you've already heard, they're anatomic, they're biomechanically efficient, they are effective. There's lots of literature about this. This is just 2 papers. They're safe, they've got a very low complication rate. The problem is that they are inadequate in alter or severe dysplasia. They just can't do the job well enough on their own, and there is a higher rate of failure. If you see severe trochlear dysplasia, think about a trochleoplasty. Having worked in a specialist clinic in Bristol and now with Pete Thompson, Tim Spaulding up in Coventry, actually I see a much larger number of these. In the series from Bristol, where we had over 200 cases, we didn't have any professional sportsmen, but we had many keen amateur sports people. 73% said they got back to some level of sport, and we had a meniscal tear in one patient who was playing 11-a-side. So yes, we do not have professional elite athletes here, but we do have people who are able to get back to a reasonable level of sporting activity. But as you've heard, my real question is about the role of tubercle osteotomy, because I think for the majority of patients, most of those, an MPFL and the role of trochleoplasty is relatively well understood in the population. The real ongoing uncertainty, apart from rotational malalignment, which we're going to hear about, is about the role of tubercle osteotomy. Now, in my hands, there is one really, really good indication for a tibial tubercle osteotomy, and that's distalization. So, patellar alter is a major risk factor for instability. If your patella is lying on your femur when your knee is in extension, it's going to be horribly unstable. And actually, that is literally the case when people have significant alter. If you bring it down into the groove, they get much more stable. They're very, very satisfied patients. And the results are good, and there's a recent systematic review to reassure us of that. So here we go into the greater place for debate, which is, what about medialization? So medialization we know is biomechanically efficient. Fantastic paper from Joe Stephen, which is up here, that really does lay out the biomechanics very nicely. The context being that a lot of patients have a lateralized tubercle. We measured this with a high TTTG. We've seen lots of good examples of that. And you correct that high TTTG. And that is a very reasonable concept. The concern has been this, which is rates of long-term osteoarthritis. Now, accepted, some of these studies are from a number of years ago when osteotomies have changed. However, some of them, and particularly the Bristol series of Naveed, the osteotomies were quite carefully controlled. And you get quite high rates of patellofemoral osteoarthritis, particularly in the medial facet. Now, that's not to say there's not a good place for it, and I think some of the cases where you've got some degenerative change on the lateral side, actually, you're paying off one for the other, and that's entirely sensible. But beware of it, certainly beware of it, particularly in instability. And what you want to be asking yourself is, when you look at a scan, is a high TTTG because of the TT or the TG? So what is the pathology? Where does the pathology lie? Does a lateralized tubercle even exist? So we've started some work with this, and we've given our computer scientists 120 scans of abnormal cases and 120 scans of normal cases, and they've done the first 40 so far. They've done some clever stuff to tell us what the difference is between them. I've not told them what to look for. They've just gone to look for it themselves. What we see is the primary problem. Oh, an extra image has come up there. The primary two problems are pretty obvious. In fact, the most important one is the length of the patellar tendon, just emphasizing the importance of alter. In fact, that's probably more important than trochlear dysplasia. Trochlear dysplasia actually happened to some degree in almost all of these cases. Even when you're looking at it and you think, well, that's pretty normal, they've probably got some degree of trochlear dysplasia. Actually, the tubercle is sometimes lateral, but it appears to be a much more minor effect, and the differences appear to be relatively small. So there is a place for it in some patients, but it's not a universal feature and not your go-to option. So beware. The problem might not be a lateral tubercle, but be conscious of it. So part of my question was, is return to sport possible after a patellar realignment? Well, there aren't many people with the sort of experience enough to tell us that, and we've heard probably the biggest series in elite athletes that's been described. The closest thing I could find in the literature was from the Mayo Clinic, who've published on this year. It's still in press. They had 39 cases in what they called competitive athletes, although they didn't quite define quite how elite that was. 16 of those patients had tibial tubercle osteotomies. All of them had MPFL reconstructions. And they reported an 85% return to competitive pre-injury sport. In fact, interestingly, the 6 who didn't all could have gone back to sport, but decided not to because of risk of re-injury, and they're at the younger end of the spectrum. So actually, these patients do very well, and I'd suggest to you that an MPFL reconstruction with a tibial tubercle osteotomy are often the most satisfied patients you find. And I think some of the cases we saw at the start are exactly my experience. They just instantly feel better. This is a case of a high-level, not quite professional netball player that Jonathan Eldridge has sent me recently. And this isn't an instability case, but it's a case where, just to demonstrate that patients do get back and can get back to their pre-injury level with osteotomy. So this is a case of functional patella alta. Doesn't look too dramatic when you measure it out, but actually, as Charles Wakely explained, if you look at the overlap really carefully, you realize there's not a lot there. And she has a bit of proximal tendinopathy. And this was troubling her. She wasn't able to get back to sport. It was very limiting for her. And Jonathan agreed to do a distalizing osteotomy. She responded really well, was back to training by 4 months, screws out at 6 months and back playing. So in summary, this is pathological anatomy, and it's worth identifying what the pathology is. Don't introduce a new abnormality, but do correct what's pathological. Distalization, and in cases of instability with an MPFL reconstruction, is an excellent operation and is anatomic. Medialization is effective, but actually often isn't anatomic, and you've got to be very, very critical of the images you're seeing, and has a high risk of late osteoarthritis. Of course, we don't quite know the reasons for that, and we don't know if you treat them differently whether they'll still get that. So there's a lot more work to be done, but return to high-level function is possible. Thank you.
While they're all assembling, I'm going to ask you, Joe. Are we, for what you were saying with your new techniques and everything else, are we close to being able to know what is normal rotation and what is abnormal? And are we close to being able to work out what we should operate on and what we shouldn't?
I think with the work that we're doing, we're going to get closer to that, yes, would be the answer. But I don't think we have those answers at present, unfortunately.
It's amazing. I mean, you're doing all this work and everything you're presenting is amazing. And I'll never forget in my fellowship in Australia, we had a girl with classic miserable malalignment. And I worked with a really talented surgeon called Peter Neer, who is a paediatric orthopod. And he spoke for a long time about rotational malalignment. And then he said, so what we do is we just make a cut here and do an osteotomy and rotate the femur until the patella's pointing at the ceiling. And then we make a cut down by the ankle and rotate the foot until it's pointing at the ceiling. And then we just fix it in those positions. And you think about all this work that's going on, and that's actually what people actually do in the end. That's where we are.
I'm just fascinated that you know that the operation works for elite athletes. Why don't you do the same for your normal patient?
That's a great question and a very obvious one. I like the logic of correcting abnormalities in the hope that there may be less OA long term. But that's all I can say. And so there is a logic to doing all the aspects of it. There's a Kieran McCool, who may or may not be here, saved my life last year. There's an extremely high-risk patient, a very delicate individual, mentally and physically, and I was going to do the full house, apart from a trochleoplasty. And he phoned me up and said, "Are you sure?" And she's a yoga instructor as well. Her only request was, "I've got to be able to get to 140 degrees bend." And I just thought, you're right. There was lots of psychosocial stuff which I'd sort of picked up. You know, sometimes when you examine a knee, for example, you pick it up and you ignore it, and then you think, God, I thought I saw that. Why didn't it stick? And she had "do not operate" tattooed on her forehead, and I hadn't lifted her fringe up. And I knew when he phoned me, so I had to sort of swallow my pride and actually get her back. So I've changed her mind. And she's done brilliantly. She's still doing yoga, and she just had an MPFL, and she coped with it only just. So Kieran, wherever he is, I bought him a pint last night. God, I'm going to be in his debt, because she would have be like a Death Eater and suck my soul out for several. And you've all got them. Let's be frank. No, everyone's too polite and dishonest. They take a piece of me. I do care about it. I really care about it. Lovely woman, but a lot of problems. So less can be more, but it's a philosophical thing. Sam said we're going to step forward to be in the light. We're still in the dark, ladies and gentlemen. We haven't got a clue about this. And Joe's stuff, it's so obvious that if we're fiddling around at the knee, neglecting the rest of the body, the physios have got this. They've got it ahead of us by miles. We've got to rotate the femur to meet the patella, not vice versa. And so it's quite depressing, actually. All of our talks are wrong, probably, apart from the physio talks.
Quick question for Charles. When you talked about MRI being a very useful way of measuring functional patellar outer, but at the end of the day, as surgeons, we have to work out if we're doing a distalization, how far we are going to distalize it, and you can't use MRI for that, or can you? I know because you work with Jonathan Eldridge, what does he do? How does he work out how far he's going to distalize it?
I don't know exactly how far, and have you seen, does he measure? He virtually does it the same length all the time. But
the big centimetre or small centimetre?
But what I wanted to get across, is that the old measurements are misleading. They're based on bony anatomical landmarks. Most of them, even the Blackburn peel, are based on the joint or the tibia. It's got absolutely nothing to do with the femoral patellofemoral joint. I think he does roughly the same on each one, but I'll pass it over to Andy. And he's virtually given up doing any medializations, any of the others, and we have fantastic success just from distalization.
You're preaching to the converted on that one.
So, All right. So I think this is a degree of subjective judgment in this, and actually we're very good at trying to put figures in patellofemoral instability. They're really hard to measure. All the figures for trochlear dysplasia, which is all true, actually that you've got to screen up and down, get a 3D image in your head, and try and understand, because this is a complex three-dimensional problem. The challenge of dealing with ulcer is you want to bring them back into some form of a groove. And so I would tend to scroll up and down, and Jonathan very much does the same. He will scroll up and down and work out how far he wants to bring them down. It varies a bit. It's usually around 1 centimetre. But the truth is, I think there are some that you scroll down and you think this has got to go a long way, and there are some that you scroll down and you think, look, if I bring this down 6 to 8 millimetres, they're going to be in a sensible groove. You just need to get the tip of the patella into some form of groove. So it's a judgment, which is the best I can say.
And that's honest, isn't it? Which we should be. We talk as if things are known and understood. We haven't got a bloody clue about this. But you mentioned the long tendon, and you bring it down. The group in Lyon, certainly Philippe Néret's group, will suture the tendon at an appropriate height on the tibia. Do you ever consider that? And the problem is if you've got a long length, it can spin presumably either way.
Good question. I think the primary pathology is about where the tip of the patella is in the groove and extension. I think ultimately that's the problem, and we worry about insoles of article length, and I see your point about lever arms. Although, of course, when you distalize, you do have a bit of a gap under tendon that's going to be awkward I suspect you'll end up tethering it too high. But really, the pathology is about getting the tip of the patella into a form of groove. And in my mind, that's the pathology you're trying to deal with. So, you may be right, and these are difficult to understand, and I don't think we understand them that properly. But in my mind, and I think Jonathan's mind, that's the pathology you're trying to correct, and it's about bringing them into the groove and extension.
Do you think we understand what normal patellar tracking is? Because when I was training, you'd see these eminent people, always men, of course, because that's how it was. Very few women still, sadly, and they would do this, and they would get the patient to extend and flex 90 degrees and do this, and they would say, of course, patellofemoral tracking is always assessed on the articles and the papers, and it's as good as that. So, do you think we know?
No. No, I think it's complete. I find it impossible to look at. I know Jonathan largely doesn't look, and I think the patella often, in a bad dysplasia, the patella will go in every direction round a lump that it's trying to get around. And I think the best you can say is it just looks a bit funny.
Just to finish, we did some work on, we did a stand-up MRI machine at St Mary's in the late 90s. And I think our first paper was on patella tracking. And by 10 degrees flexion, the patella had engaged and centralized. I'm delighted to tell you that paper was then copied by an American group who didn't give us any recognition for having published it first. Sorry, I am damaged by that experience.
Yeah, there is an interesting paper, I think, published in the AJSM, which looked at patients who have TTTGs greater than 15 millimeters. I think it's patellofemoral pain rather than instability. They actually find they did flexion in an open MR scanner from 0 to 40 degrees. I think about 65% of them track medially, which is kind of going against, I guess, what we're trying to address if we're medializing the tibial tuberosity. The other question I had about medializing the tibial tuberosity, do any of you have concerns about medial tibial-femoral joint loading as a result of that?
I think you definitely see it in patients who are overcorrected.
Yes, we do. We do see it, and I've seen it, and I've seen actually a medial dislocation as a result of it. So it does happen. What I would like to get across, though, is none of us, as Andy said, have actually really got a clue about this. And what I've tried to get across in my talk is that even as co-author of about 3 or 4 of those papers, I still don't do the measurements that we actually define because I've changed my opinion along the way. And I've changed it over the last 10 years, 5 years, 2 years, and in fact, over the last year. So all I'm trying to do now is just throw out 5 or 6 radiological observations, which are a tiny piece of my jigsaw, which is in turn is only one fraction of the physiotherapy and surgical jigsaw. And what Joe's thrown into the mix today is yet another complete dimension, and that's the torsional profile, which none of us look at. I look at it in Bristol a lot because we do all the Elizara frames and the rotational osteotomies, the correctional osteotomies. We use exactly the same method as you. I don't care about what position their leg is in because as long as you're actually comparing the femoral neck with the femoral condyles, with the tibial condyles, with the malleoli, it just doesn't matter. But it is astounding the difference in torsion. And we are not considering this at all.
Hello, Matthew Oakley, orthopaedic surgeon. Femoral torsion. The easiest place to correct femoral torsion is up by the hip, but you've still got all the intramuscular septum and all the muscles attached to it. If you want to affect the knee, surely we should be doing the osteotomy close to the knee.
I would argue we don't know, and that's why we want to do this study. But I agree with you, it makes perfect sense if you go distally that actually you're internally rotating all your muscles, which would make sense. And that's what I've done, and I've got great results. But the honest answer, as Andy says, we just don't know, and that's why we need to look at it. I just want to throw a question back to Joe, actually, on the point that you just made. Do you femoral anteversion is very interesting with relationship with patella alter trochlear dysplasia. Do you think femoral rotation drives coronal alignment?
Absolutely, yeah. I think it definitely does.
Why?
Well, I think when you change alignment in one plane, it will have an effect in another plane.
So I mean, the footballers, one of the joys of going to see a real live match, you don't see it on TV, but when they wind up to accelerate off, they externally rotate. So you look at Hazard, well, you won't see Da Costa anymore because he can't be asked, but when he signs for a new club, you'll see it. They turn out and they drive off, and it maximises the lever arm of their glutes, and they're all in varus, aren't they? And so we've had this obsession about varus making a good footballer without thinking about above and below. I mean, it's a terrible way to end a conference, isn't it? We just don't know anything. There is apparently free Prozac outside.
Hugo.
Hugo Guthrie, orthopaedic surgeon. Do you worry about, talking about patella alta and its importance with recurrent instability, should I be worrying about distalization in recurrent unstable patella patients who have already got chondral damage, as long as I'm not medializing them? If I'm just distalizing them, what am I doing to their contact pressures?
So you're moving their contact pressures proximally on the patella. Now, actually, this is, I think, not quite a good indication sometimes when you've got distal wear. So distal pole wear tends to go with your patellar alta patients. And if you've got that pattern of distal pole wear, patellar alta, they seem to do quite well with a tubercle osteotomy. There's not a whole lot of data out there on that. I think we're trying to collect some right now. But actually that biomechanically makes sense. You are going to move their contact forces proximally and hopefully offload that section. If you're mid-patellar, a bit more of a challenge, and I'd be a lot more wary about those.
And again, we don't really understand it, but as you go proximal, the width of contact increases, so I guess that would offload. But there was a procedure called the Mackay procedure, which tuberosity was elevated and twisted up and bone put behind it to anteriorize. The idea being it would lift the patella away from the bad stuff. It was unmitigated disaster in most cases, but it was said there was an indication for inferior pole OA, but would you agree with that? I mean, I've seen patients who've had it done, and they have ridiculous looking prominent tibia and lots of problems, they can't kneel, etc.
So likewise, I think it's a rubbish operation. But the pattern, the consistent pattern is your inferior pole is often goes with alta, and it's about identifying what's the anatomical abnormality. Goes back to that thing, what's the anatomical abnormality that's led to that problem, and deal with that. And so it may be that the Mackays were actually slightly distalizing. Yeah. That would be my guess.
The few that worked.
The few that worked, yeah. But I've seen patients who've had them, and they're miserable. Yeah, agreed.
Sean.
Yes, sorry. I just wanted to go back to the biomechanics on the rotational malalignment. I think it is something we definitely are missing. From my background in doing children's stuff, we looked at that for neuromuscular conditions in CP. I think there is good evidence from the gait analysis on these that doing proximal derotation osteotomies does alter the biomechanics of the patellofemoral joint. There's no doubt that it does improve it. What we haven't also talked about is the coronal alignment, and no one's sort of talked about that.
I think we have in terms of Q angle, etc. I mean, were you getting something else I may not have understood?
No, just so the bony, rather than the Q angle, actually looking at the bony alignment in the coronal plane.
You mean varus and valgus.
I think it's important because I do think that there is a group, particularly with the hypoplastic lateral femoral condyles who drift into valgus. You need to address that as well.
Agreed.
Very quick question for me to Simon. Do you think that we can pick up kids, adolescents with potential patellar instability going forward and do something, intervene with physiotherapy or education in order to prevent them from dislocating in the future? And do you know of any screening programs at high-level sport, academy level, whatever, that are doing that?
So I'm an eternal optimist, so I'd like to think that we could. But I suppose sort of trying to sum up type of this discussion, I suppose, is that what we're identifying is a three-dimensional or potentially a three-dimensional problem, or that the problem could exist in any one of three dimensions. And some of that may be due to structural abnormality, some of that may be due to some of the sort of neuromuscular side of things, some of that could be, like I was trying to allude to, I suppose, like the loading aspect of it. It could just be that, yeah, they don't have brilliant mechanics, like you were saying, but they've made it sort of maybe to 21, but if they've been more sort of appropriately educated or trained and so on, then they may stay within that envelope of function for longer and get beyond that 21 tipping point where then actually they end up getting symptoms. So I'm not aware of a program that is intervening in that way prospectively with a view to reducing risks. So that kind of answers that. But yeah, I think we've got a three-dimensional problem. I think that there is a priority for us to identify in which dimension their primary deficit exists in, and then us intervening appropriately, whether that is one that I think as a physio we might be able to improve by a few degrees and that might bring them back into an envelope of function, or whether actually that's beyond the scope of a rehabilitative program or a load management program, and it requires something more on a structural basis. But I suppose that's where the sort of collaboration aspect or teamwork between the two sort of is required, and it's not one size fits all.
There was a meeting I was at over in the US where I think they are looking into trying to identify patients who are the children of people who've dislocated their knees, because that's the group that you could pick, I think, and prospectively look at. So I think there is some work that they're trying to do at the American Sports Association on that.
Thank you to the faculty. Thank you to you all for staying, and get home safely. Cheers.